talk will be about PET-directed radiation, specifically for the treatment of oligometastatic disease. Before I dive too far into it, I think a number of words have been said about Dr. Felix Fang, who is one of my mentors and friends, and he was just remarkable. I think a lot of us here have a lot to say about him. He and I used to give a version of this talk together, so you'll actually see some of his slides kind of interspersed throughout. So he actually changed his outfit so that we were dressed the same way to see if we could confuse people that day. So, all right. I often say that no discussion of oligometastatic cancer is complete without this slide, which I guess is cut off. Oh, it's cut off on my screen, but here. It's actually a slide that Felix put together. There's no conversation that's complete without a discussion of the University of Chicago. Sam Hellman and Ralph Wexelbaum there years ago had proposed that across all types of cancer, that there was this intermediate state of cancer that basically existed between localized disease and metastatic disease. And it's somewhat, I think, intuitive that there's this sort of spectrum of aggressiveness where there may be situations that are more amenable to certain types of treatments. At that point, and even still today, oligometastatic cancer has been pretty crudely defined, mostly based on the number of metastases that we see on a given image. But one of the sort of consequential things that they said now 30 years ago was that an attractive consequence of the presence of a clinically significant oligometastatic state is that some patients may have a disease that's amenable to curative therapies. And so that sort of sparked this interest in trying to treat the oligometastatic state more aggressively and potentially, provide some long-term disease control, potentially cure. There's been a lot of sort of discussion around what represents oligometastasis. How do we identify the folks that have disease that's most amenable to treatment? This is kind of one piece of the puzzle that came over from Europe with this idea of synchronous oligometastatic disease, which is metastases that are detected at the time of diagnosis, and then metachronous oligorecurrence, that is when cancer comes back later on in very limited areas. And again, this is true for kind of all cancers that we see. And most of the data, actually, the preponderance of data in oligometastasis is in prostate cancer. And specifically, most of the data is in what we call metachronous oligorecurrence. So again, sort of in folks that have been treated before, but the cancer has come back in a metastasis in very limited areas. The Hellman and Wexelbaum theory sort of proposed that maybe we can treat these areas aggressively. And almost, in that sort of same era, there became sort of technologies that were more available to us on the radiation side, namely stereotactic body radiation therapy, or SBRT. I mentioned SBRT earlier as a treatment modality for primary prostate cancer, but we also use it for other types of cancers, which I sort of alluded to. And we use it specifically also for other types, for oligometastasis. SBRT sort of first became popularized in brain tumors and in pulmonary tumors, and then sort of expanded to a number of other cancers. And in oligometastasis, we use it to treat areas of metastases. This is a picture of a lung metastasis for an SBRT plan that we had for a patient with oligometastatic cancer. And the idea is to treat with high precision image guidance and high dose radiation in 5 or fewer treatments. And so it was the technology that enabled very good, strong localization in real time of sometimes static, sometimes moving targets that enabled SBRT that we see today. And that allows us to deliver radiation doses that we weren't able to spatially resolve before. In prostate cancer, no one is actually intended to memorize any of this stuff. Rahul actually asked if I wanted to remove the slide. But this is just kind of a representative example of all of the studies that we now have in the prostate cancer space that support the use of what we call metastasis-directed therapy with radiation. If any of you guys are readers, they're all things that you can look up. But I'll highlight that a number of them, or all of them, are phase 2 clinical trials, kind of going back to, I think, Dr. Agrawal's talk earlier. And these are all randomized, sort of earlier trials that sort of all show some type of advantage in incorporating focal radiation into the treatment of oligometastatic cancer. JAMA Oncology has nice diagrams for all of us. And so I thought I'd include this as one example. This is the Extend trial from MD Anderson, and this is actually one that tested the question of adding SBRT or not while folks were getting hormone therapy. So one of the kind of more unique questions that have been asked in the oligometastatic space. But it's a nice diagram to kind of summarize, sort of how these studies kind of come together. The idea in this study was to basically look at how long men lived without prostate cancer while their testosterone had recovered off of hormone therapy. So, and radiation increased the duration. One sort of attractive part of treating oligometastases with stereotactic radiation is that the toxicity profile tends to be pretty favorable when we treat oligometastases, and a lot of this is a consequence of how focused and tight the radiation fields are. The SABRE COMET trial was an oligometastasis trial across all different cancers, but one of the helpful elements for us in this room is the side effect profile. And so, at least in the shorter follow-up that they had over several years, there were no differences in quality of life that they found, despite treating a number of different parts of the body with SBRT. And so as Tom mentioned earlier, imaging is getting better, and some of those trials that I showed you on the slide earlier were derived in sort of the more conventional staging era, and PSMA has certainly transformed what we're able to detect, and it's fundamentally important to how we define SBRT for oligometastases. And one of the few trials that incorporated PSMA PET scans was the ORIOLE trial from Johns Hopkins. And one of the things that they did, this is early in the PSMA PET era, but one of the things they did was they went back and looked, and even though they didn't use PSMA PET for designing the radiation fields, they looked at those folks whose treatments covered all of the PSMA avid lesions, as opposed to missing some of the PSMA avid areas. And then they found that if you, which this should, I think, is likely intuitive, if you treated all of the areas on PSMA PET, you had better outcomes. This kind of gives you a little bit of a feel. This is the x-axis is time, but the y-axis is the rate of progression-free survival. And so you can see that there are a number of favorable outcomes on this small trial. I roped Dr. Small into giving this talk with me last year, and he let me keep one of his slides, so I'm going to keep that in here too. But we often encounter the question of whether or not we should add hormone therapy onto radiation when we do metastasis-directed therapy. A number of the trials that I showed before use radiation as a mechanism to delay using additional treatment. Here we sort of try to come up with a personalized plan that incorporates considerations around both the side effects. This kind of goes to our earlier discussion, side effects and the advantages of adding on hormone therapy. A number of the study, the sort of gold standard treatment in metastatic prostate cancer remains systemic therapy. And so, the question of kind of de-escalating that alongside radiation is kind of an open one. These are some of the characteristics that Dr. Small and his colleagues, I won't put words in Dr. Agarwal's now, but this slide came from Dr. Small, but a number of the characteristics that we consider on trying to decide whether or not there's an advantage to adding on hormone therapy, augmenting the hormone therapy and whatnot. That's all I've got. Thank you.